Good afternoon, everyone. Welcome to Cardiology 305. Today we're discussing palpitation, that's skipping, racing, pounding feeling, symptoms and clinical characteristics. I'm Dr. Fernandez, and by the end of this session, you'll have a clear systemic approach to evaluating and managing this common but sometimes concerning symptom. Learning objectives. Here are our learning objectives for today. By the end, you will be able to define palpitations and describe how patients typically present, characterize symptoms, including patterns and associated features, identify cardiac, non-cardiac, and rare etiologies with emphasis on high-risk causes. Outline the systemic diagnosis workup, including EKG, labs, and ambulatory monitoring. Apply risk stratification and recognize red flags while using advanced testing and implementing evidence-based etiology-specific management strategies. The definition of palpitations. Palpitations are defined as an abnormal, unpleasant awareness of the heartbeat. They affect up to 60% of medical outpatients. Patients commonly describe them as racing, fluttering, pounding, irregular, skip beats, or even a pounding sensation in the neck. The American Heart Association describes them as irregular, rapid, fluttering, skipping, or pausing heartbeats. Remember, palpitations are a symptom, not a diagnosis. Detailed characterization is essential to guide our evaluation. Symptoms, characterization, quality and pattern. Quality and pattern give us critical clues. Rapid and regular palpitations suggest paroxysmal supraventricular tachycardia or ventricular tachycardia. Rapid and irregular point towards atrial fibrillation or atrial flutter. Irregular with pauses or skip beats often represent premature atrial or ventricular contractions. A simple bedside technique is to ask the patient to tap out the rhythm with their fingers. This quickly maneuver is highly diagnostic. Mode of onset, termination, and triggers. The mode of onset and termination is often more diagnostic than the symptom itself. Abrupt onset and termination strongly suggest re-entry arrhythmia such as paroxysmal ventricular tachycardia or ventricular tachycardia. Gradual acceleration and terminations are typical of sinus tachycardia, which may be physiologic or secondary to systemic conditions. If the palpitations can be terminated by vagal maneuvers like a Valsalva, this points to AVNRT or AVRT. Palpitations triggered by exercise without emotional stress are more likely arrhythmic, while those linked to excitement, fear, or psychological stress often represent sinus tachycardias or a heightened awareness. Associated symptoms and clinical clues. Always ask about associated symptoms. They guide risk management. Common accompaniments include chest pain, dyspnea, lightheaded, fatigue, pre-syncope, syncope, and diaphoresis. Polyuria during episodes suggests sustained supraventricular tachycardia due to atrial natriuretic peptide release. In atrial fibrillation specifically, patients frequently report fatigue in 26 to 75% of cases, dyspnea in 28 to 76%, and other symptoms such as dizziness, chest pain, and anxiety. Importantly, palpitations occurring during exercise or sleep raise concern for more malignant arrhythmia and warrant urgent evaluation. Physical examination findings. On a physical examination, look carefully at the neck and Canon A waves in the jugular venous pulse. These large pulsations occur when the atrium contracts against a closed tricuspid valve and are highly specific for atrioventricular dissociation, seen in AVNRT with simultaneous contraction, ventricular tachycardia, or complete heart block. Also assess for murmurs, a displaced point of maximum impulse or sign of heart failure which suggests underlying structural heart disease. Additional clues include thyroid enlargement for hyperthyroidism, pallor for anemia, or tremor for anxiety or hyperthyroidism. Cardiac etiologies, arrhythmias. cardiac causes account for approximately 43% of palpitation cases, and arrhythmias are responsible for 91% of those cardiac presentations. The most important arrhythmia include atrial fibrillation, which is the most common arrhythmia leading to hospitalization, atrial flutter, supraventricular tachycardias such as AVNRT and AVRT, and atrial tachycardias, ventricular tachycardias, and premature contraction, both PACs and PVCs. PVCs are found in about 50% of people on longer monitoring and increase in frequency with age. Frequent PVCs, or premature ventricular contraction, defined as more than 30 per hour or over 10,000 to 20,000 per day, are associated with increased cardiovascular risk and cause PVC-induced cardiomyopathy that is often reversible with suppression. Structural disease and channelopathies. Beyond arrhythmias, structural heart disease can cause palpitation through direct arrhythmogenic effect or increased cardiac awareness. This includes a mitral valve prolapse, hypertrophic cardiomyopathy, valvular regurgitation, congenital heart disease, atrial myxoma, and mechanical prosthetic valve. Inherited channelopathies are particularly important because of sudden death risk. Brugada syndrome, long QT syndrome with QTc threshold of greater than 460 milliseconds in females and greater than 440 milliseconds in male, and short QT syndrome. A high output state such as anemia, pregnancy, fever, or arteriovenous shunt can also precipitate palpitations by increasing cardiac workload and causing sinus tachycardia. Non-cardiac and rare etiologies. And non-cardiac causes are common. Psychiatric disorders including anxiety, a panic disorder, depression, and somatization account for about 31% of some series. But remember that psychiatric comorbidities does not exclude a cardiac etiology. Always evaluate thoroughly. Metabolic and endocrine disorders are frequent. Hyperthyroid classically causes sinus tachycardia or atrial fibrillation, while hypoglycemia, pheochromocytoma, and electrolyte imbalance can also trigger symptoms. Drug-induced palpitation result from caffeine, nicotine, alcohol, stimulants, beta agonists, corticosteroids, digoxin, and various supplements. Rare etiologies to consider when common causes are excluded include postural orthostatic tachycardia syndrome, inappropriate sinus tachycardia, long COVID-related autonomic dysfunction, and systemic mastocytosis. Up to 16% of cases remain idiopathic after throughout evaluation. Initial diagnostic evaluation. The cornerstone of evaluation remains a thorough history and physical examination. Key historical predictors of a cardiac etiology include male sex, description of an irregular heartbeat, history of heart disease, and a palpitation lasting longer than 5 minutes. A baseline 12-lead EKG is universally recommended and has a diagnostic yield of 3 to 26%. This yield rises significantly when the EKG is captured during symptoms. Initial laboratory evaluation should include a complete blood count (CBC), comprehensive metabolic panel (CMP), thyroid function studies, and magnesium level. In women with reproductive age, obtain a beta HCG. Cardiac biomarkers are reserved for cases with sustained arrhythmia, suspected ischemia, or hemodynamic instability. Ambulatory ECG monitoring. When the initial ECG is non-diagnostic but suspicion for arrhythmia remains high, ambulatory ECG monitoring is the next step. A device selection depends on symptoms frequency. Holter monitors for 24 to 48 hours are appropriate for daily symptoms with a yield of 10 to 15%. Standard monitors worn for up to 2 weeks offer the highest diagnostic yield to cost ratio of 70 to 85%. Event recorders and loop monitors work well for infrequent symptoms. Implantable loop recorders provide the highest overall yield of 80 to 90% and are reserved for cases where external monitoring is non-diagnostic. Wearable and advanced testing. Wearable devices have become valuable adjuncts. Smartwatches using photoplethysmography or single lead EKG show high accuracy with pulse sensitivity near 100% and specificity around 95% in large meta-analysis. They can provide useful symptoms rhythm correlation and reassurance when normal sinus rhythm is documented during symptoms. However, the U.S. Preventive Service Task Force currently finds insufficient evidence for population level atrial fibrillation screening with wearables. Additional testing includes transthoracic echocardiography for patients with abnormal physical findings, abnormal EKG, syncope or family history of hypertrophic cardiomyopathy, or sudden cardiac death. Exercise stress testing is indicated for exercise-associated palpitations or suspected ischemia. An electrophysiological study is reserved for selected cases with non-diagnostic monitor plus tachycardia or syncope. Risk stratification and red flags. Effective risk stratification is essential to identify patients at high risk for sudden cardiac death or serious arrhythmia. High risk features warranting urgent evaluation include syncope or pre-syncope with palpitations, especially during exertion, hemodynamic instability, personal history of structural heart disease, a family history of sudden cardiac death, or inherited channelopathies, and palpitations occurring during exercise or sleep. High risk ECG findings include the Brugada pattern, a long QT interval, a wide complex tachycardia, or ventricular ectopy in patients with non-cardiac disease. In contrast, low-risk patients with a normal heartbeat, normal ECG, no syncope, and only brief isolated palpitations can generally be reassured and are managed conservatively. General management principle. Management of palpitation is fundamental etiology specific. All patients should receive counseling to avoid adrenergic substances such as caffeine, nicotine, and illicit drugs to optimize cardiac risk factors and to address lifestyle contributors, including stress and poor sleep hygiene. Patient education and reassurance are powerful tools, especially for benign or idiopathic cases. In patients with structural normal heart, the prognosis is excellent, with no increased risk of mortality or major adverse cardiac event. Wearable devices can further support reassurance by documenting normal sinus rhythm during symptomatic episodes. Acute management of PSVT. For acute episode of paroxysmal supraventricular tachycardia or hemodynamic stable patients begin with vagal maneuvers. The modified Valsalva maneuver performed supine with leg elevation has approximately 43% success. If successful, administer intravenous adenosine 6 mg as a rapid push followed immediately by a saline flush. Repeat at 12 mg if needed for an overall success rate of 91%. In hemodynamically unstable patients, proceed immediately to synchronize cardioversion. Long-term management recurrent paroxysmal supraventricular tachycardia. For prevention of recurrent PSVT, catheter ablation is now recommended as a first-line definitive therapy, with single procedure success rate of 94 to 98.5% in meta-analysis. When ablation is not immediately feasible or is declined, pharmacological options include a beta blocker or non-dihydropyridine calcium channel blockers such as verapamil or diltiazem. Antiarrhythmic drugs are reserved for cases where ablation is not possible. Overall, ablation offers the most durable benefit and is often preferred for symptomatic patients. Management by specific etiology. For atrial fibrillation or atrial flutter, rate control with beta blockers or non-dehydropiridine calcium channel blockers is the first line. Rhythm control strategies or catheter ablation are appropriate for selected symptomatic patients. Atrial flutter ablation is often preferred because rate control can be difficult. For isolated premature atrial or ventricular contraction without structural heart disease, a reassurance is usually sufficient. Beta blockers or calcium channel blockers may be used for symptomatic relief. Catheter ablation is indicated for high ectopy burden or PVC induced cardiomyopathy, typically when PVC exceeds 10,000 to 20,000 per day with a depressed left ventricular function. Management by specific etiology. For non-sustained ventricular tachycardia, first correct any reversible factors and exclude ischemia. Then consider beta blockers or calcium channel blockers. Ablation is used for refractory cases. Inappropriate sinus tachycardia is a diagnosis of exclusion after ruling out secondary causes. Management includes lifestyle modifications, beta blockers, calcium channel blockers, or ibabridine. Structural yoga practice for 45 to 60 minutes at least 3 days per week has been shown to reduce symptoms burden. For non-cardiac causes, direct treatment at the underlying condition, correct thyroid dysfunction or electrolytes, discontinue offending substance, and use cognitive behavioral therapy for psychiatric etiology. Diagnostic yield of monitoring modalities. Here's a summary of the diagnostic yield to guide device selection. Holter monitor over 24 to 48 hours yield 10 to 15% for daily symptom. Extended external patch monitor up to 2 weeks provide the best yield to cost ratio at 70 to 85%. Event and loop recorders are useful for infrequent symptoms with variable yield. An implantable loop recorder achieve 80 to 90% yield and are reserved for cases where external monitoring fails. Wearables, smart devices offer approximately 97% overall accuracy as a helpful adjunct for symptomatic correlation. Risk stratification algorithm. Use this simpler risk stratification framework. A high-risk patients with syncope, a structural heart disease, a family history of sudden death, exertional palpitations, or abnormal EKG findings require an urgent cardiology referral and monitoring. An intermediate risk patient with frequent or prolonged symptoms but no red flags should undergo ambulatory monitoring plus echocardiography. Low risk patients with brief isolated palpitations, normal cardiac exam and EKG, and no syncope and can be reassured with lifestyle advice. Patients with structural normal heart have an excellent long-term prognosis. Summary and take-home points. To summarize, palpitations are common and require a systemic approach beginning with detailed history and EKG. Distinguish benign causes such as isolated PVCs or anxiety from a life-threatening arrhythmia using red flags and targeted monitoring. Catheter ablation is highly effective and frequently first line for reentrant SVTs and selected cases of atrial fibrillation or flutter. Reassurance combined with lifestyle modification remains the cornerstone for low risk and idiopathic palpitations. When structural heart disease is absent, the long-term prognosis is excellent. Patient education and transparency helps build trust and improve outcomes. Key clinical perils. Here are some practical clinical perils to take with you. Always rule out cardiac causes before attributing symptoms solely to anxiety. Ask every patient to tap out the rhythm. It is quick, inexpensive, and often diagnostic. Wearable expand diagnostic access, but still require clinician interpretation. Frequent PVCs can cause reversible cardiomyopathy, and suppression therapy can restore left ventricular function. Finally, the modified Valsalva maneuver is superior to the standard Valsalva for terminating paroxysmal supraventricular tachycardias. These are the key reference. The content today is drawn from high impacted sources, including the 2024 American Family Physician Review, the 1998 New England Journal of Medicine article, the 2024 JAMA article,